You're welcome to move a little closer if you'd like to, make it a bit more personable. I also wanted to introduce, thank you for that introduction, I also wanted to introduce some very good friends that I've met in the course of this project. Jill and Peter Lindley, who have also come up with us today to talk, and you'll hear their stories and hear why this is such an important activity for us and why we're so excited to be here to present to you. We've also, they're also part of our steering committee, and I'd be very grateful if you wanted to look into this further. Peter and Jill have also been huge advocates for hearing impaired consumers for many, many decades, and if you Google Peter and look at the articles he's produced, I think you'll agree they're quite spectacular. So I'll get along. Just a quick, this is us. We're at Redland. It's actually a fantastic little place on the bay. Very small community facility. There's 140 beds, but that covers mental health, medical, surgical, maternity services. So, and it's a very busy emergency department, almost 60,000 presentations. That's very significant because of the small bed stock. It's quite unusual like that, similar in size to Caboolture. So very busy department, a lot of stress, a lot of anxiety, and we know now what that does to communication and why communication is so important. I just wanted to highlight to you what we're going to go through today and sort of try and talk you through the settings and the problem we're trying to solve, why it's so important, and this different strategy we took to try and improve, and where we're at and what we're going to do next. The exciting thing for us is that it started from a complaint, or as we like to think of them, a gift, an opportunity. And when you take that approach, we know that we had a problem and we were uncomfortable that we had a problem. Yes, we tried to fix it, but the fix wasn't sustained. So we thought we had to do things a little differently, and thus the project commenced. So to help me try and set the scene, I just wanted to put it into context. Above there are some of the strategies that are in place in Metro South that are relevant to our cause. And there are many, and I put a lot of them up there on purpose because there's actually quite a lot of focus in the area of person-centredness. You may or may not know that Metro South has embarked upon plane tree credentialing. And while we don't have time here today, I'd encourage you to have a look at their site for many opportunities that it brings from an executive level to become person-centred, or to put the question, how person-centred is your facility? But as you can see there are a number of other strategies, and the links there should lead you to them when you get to if you have this presentation. So for us, we actually know that hearing loss affects 1 in 6 patients, 1 in 6 people in our community, and actually in healthcare settings that's higher. So we know that it happens a lot, and we also realise that we don't have all the answers, and its impact is great. To help me sort of talk you through this, I wanted to first call on Shirley to tell us a little bit of her story and the significance for her. Thanks, Shirley.
Hello and good afternoon. I'm really happy to be with you here today and add to what we are trying to do with communication, hearing loss issues within our local Redlands Hospital. First, my name is Shelly Edwards. I have had a hearing loss for some 40 years and which has never been diagnosed. During those years, I have had a long and varied experience with Queensland healthcare systems, resulting in good and bad conclusions. I tell personnel in the healthcare roles and explain that I have a hearing loss, and if they slow down their speech, communication will be much easier and have better outcomes. This is not always understood, and sometimes results in myself being shouted at by professionals. Personnel taking it upon themselves to going away and getting a sign language interpreter. The staff simply don't understand that I don't understand sign language, and this is not what I need. And I just can't hear properly, that's all. These are the main negatives in my experiences. As well, one of the most responses I get is, "Oh, she has a cochlear implant, she can hear okay. No need for any insistence." This could not be further from the truth. I also experienced sheer frustration, particularly when the occasion arose that I was in hospital, of lying on a hospital bed and trying both to hear and lip read medical professionals when I was lying down and he was standing up at an angle like that. It's impossible to lip read. There are 3 categories of hearing loss. None of them you can put in the same basket. The first one is being born deaf, use sign language, and they have no oral language. The second one is those who wear hearing aids. They have oral language, they hear and they speak. And the third term is a new breed of hearing loss, people who have cochlear implants, who speak but hear with a new kind of sound that is learnt over time and lip read. All the above need different communication needs. They cannot be put in the same basket, as I've said before. I have never been asked what type of communication that I need in all my years of dealing with Queensland health systems and other government departments. In fact, wherever I go, I believe education and training is the key, and communication awareness with people who have a hearing loss be made compulsory as part of medical training. This would only result in positive outcomes for everybody concerned. For your information, I have more information here on cochlear implants, some handouts if anyone would like them, a battery service that our organisation now has as a service to our members. And we have a book at a cost of $10, which we published last year, made up of stories of people who have had implants and how their lives were changed, being able to hear again. I also have a few of our latest magazines, free if you want them, published just last week. So thank you for listening. Are there any questions?
Thanks, Shirley. We might hold the questions till the end, make sure we've got time. Hold them to the end. I'd like to introduce Peter.
Good afternoon. My name's Peter Lindley. I lost my hearing when I was 7 years old, and I'm 79 now. And as a result, I have had a profound sensory neural loss for more than 72 years. During those years, I have generally had negative experiences with Queensland's healthcare system, as I discovered early in my life that healthcare workers do not seem to take hearing loss seriously. For example, I always tell health personnel that I have a hearing loss and explain that they need to face me and speak clearly and not too quickly. Because people with hearing loss cannot process spoken information, at the same rate as a person who has good hearing. The first most common response I invariably receive is, "No problem." However, yes, it is a problem, a very big problem. The second response I receive is, "That's fine, that's fine." But the problem is it's not fine. Again, it's a very big problem. Finally, I also get one of the most common responses I receive is the third most common response is a blank look, as much as to say, "He has a cochlear implant. What is this about?" The fourth response is obvious impatience, and sometimes the comment, "Why don't you turn that thing up?" What invariably follows is they make no attempt to speak clearly or more slowly. Nothing changes. Over the years, I have experienced medication and treatment errors through poor communication. I could describe these errors, the put-downs and the embarrassment I have experienced. However, time does not permit. Good communication is prerequisite for good health and is also very important as a safety issue. Yeah, thanks. Thank you. We believe that education about the implications of hearing loss is a very important requirement. Hearing loss should be considered for what it is, a significantly disabling condition with the potential for treatment errors and a failure to adhere to each individual's right under the requirements of the Disability Discrimination Act. Thank you.
Thanks, Peter. So, for the project itself, we knew we had a problem that we were uncomfortable with, and we were very keen to fix it. Importantly, the way it was set up was really significant because we had fantastic executive leadership, and Gail Gordon's been our executive sponsor. We also have consumers on our steering panel, as you've heard, but we wanted to use a scientific approach. That very simple looking diagram where we plan, do, study and act was the approach that we used, and our planning phase actually continues throughout the cycle. Our research question that we hope to publish work on to help us understand how change happens involves a couple of aspects. Firstly, we wanted to investigate the experience of hard of hearing and deaf patients and how they access our services. And the question about improvement, how we do improvement methodology. When we do it with consumers, with external partners, and executive-led, do the changes that the staff implement in the service remain? Are they sustained? So to do this, we had a couple of strategies. The first of which we started in the emergency department with a couple of aspects around discovering the information about our current state. So we launched with great fanfare, went to the emergency department and asked them how they felt. about their confidence and their abilities and their ward's ability to service the needs of hearing impaired consumers. We also were interested to know the frequency that they thought interactions occurred, bearing in mind it's more than 1 in 6. We actually had a wide variety of responses around the perception of the frequency in which they contacted patients. The graph there is a little example of the department's awareness in the blue and the individual awareness, just ranging from not aware to extremely aware. The picture on the right there is a very fantastic emergency clinical nurse, Michelle. Michelle is our local champion. That was one of the strategies that the project thought would help us with getting inside the culture of the department. She's the leader of the Standard 2 committee, Engaged Consumers Committee, and she's got in her hand some of the equipment that we were reviewing with the survey. We also had an audit process. We used, and special thanks to the Princess Alexandra Hospital Audiology Department for their departmental audit tool that we used, and to Shirley and the lovely Alicia, who was the project officer for this project. When we did our audit with Shirley, we walked through the department and tried to discover how the department was able to fulfil the needs of consumers with hearing impairment. The results there on the right were framed as things that were done well, and then the opportunities. And I do know from that experience, we wanted to change things right then and there, Shirley, didn't we? We were very keen to turn the chairs around in the emergency department so that they faced the right way. We wanted carpet, we wanted everything. And I think that's part of the learning of this, is that we're impatient for change, but we have to do it in a way that staff agree, consumers agree, and is aligned with executive. We used a couple of tools to help us with this process. You may have seen this very simple tool called a pick chart. From all the information we'd gathered from the survey and from the audits, we asked staff to rate them on how easy or hard they were to do, and then what sort of gains we'd get from them. Whether they were easy to do, but and would pay off in a high, give us good return. We thought these were the ones that we would just do, and there were quite a few of those. We ended up with a lot of actions from it. Just very quickly, this is one of the other tools. It's often called a storyboard report, and it's a communication tool where all of the staff can see how we're progressing. On the right-hand column are the list of things that the staff, our steering committee and consumers agreed would action. So we're using the same tool, we're just updating it for every occasion. It's good for telling the background to the story for people new to it. Outcomes so far, really great effect on our equipment stores. We had equipment, but it was in the bottom drawer with rusty batteries, and we didn't have people who knew how to use it well. It's now part of standardised equipment. When you need a new pocket talker, for example, you call up equipment stores and they bring one to you, and it's ready to go. The environment, that is a huge challenge. We don't design hospitals with noise reduction strategies in mind. But most importantly for us, around the behaviours. We have to figure out ways to understand what barriers there are to implementing the best listening behaviours, and what training strategies that we're currently in the process of developing, we will be with consumers, using simulation training and experience-based learning. This is one example of one of the signs that we changed, and because we're trying to do two things, we're trying to influence staff behaviour, and by asking, we'll try to face you, we'll speak clearly and not too quickly, and check that you understand. That's important for everyone, regardless of their level of hearing. We also added a continuous improvement comment so that we could find opportunities to improve if they had an experience different to what we were trying to deliver. Time's up, so I'll just show that lovely lady in the middle there is Gail Gordon, and she's been fantastic for maintaining momentum and communicating to executive when it goes across boundaries of departments. We are off to X-ray, pharmacy and pathology next. And in the future, we know we're in for the long haul. I'd recommend that paper from Plaintree. Hearing Awareness Week is from August the 21st. That's not a picture of me. How much time do we have? Yes.
Thank you. It's really interesting, really good to see that you've done it in a way that's got improvement, which is great. I was just curious whether you've noted, because like one of your last slides said, it's important for not all people, not just people with hearing problems. Have you noticed any other benefits that those teams are getting maybe in helping other people with like any other disability needs or anything else?
Yeah, actually, all of our, Actually, most of my work is around clinical communication, safe clinical communication. So this affects everything in our facility now. Every opportunity we can, particularly when patients are stressed, how do we recognise this in people? How do we take time to quarantine time for our staff to make sure they look at the person in front of them and be there in the moment for them? We have a lot of stress on our staff, and it's easy to do it well when you have time. How do we do it well when we don't have time? It affects everything we do. One more question. Yes.
Firstly, apologies for coming late. I was held up by the other speaker who wanted to give me some feedback, and I really wanted to be here, so my apologies. But what I did hear was very important, and I just heard a little bit you talking about changing some things in the environment, and I have already said some things already today about the fact that I'm a care partner for someone who's living with dementia, younger onset dementia, and what they're discovering more and more is that a lot of people with dementia have a lot of neurological sensory challenges, whether it be visual, hearing, every sense, smell. And we were just in a conference, John presented at the Alzheimer's Disease International Conference in Kyoto only at the end of April, and there were people there who were walking around with their hands on their ears like this because they couldn't hear. Now, those people don't have anything wrong with their ears. John has neurological visual issues, and sometimes his brain just doesn't tell him what he can see. So if you're going to spend any money in the hospital, please encourage conversation and the narrative from every one of the disabilities, whether it be mental health, vision impairment, everything, because it'd be terrible to think that you may put in a carpet to reduce the noise and then it'd be an issue for someone with a visual issue, because a lot of people with dementia can interpret stripes on a carpet to be steps or dark spots to be holes. So take that consultation process, please. Thank you.
Absolutely will do and have done. And the carpet isn't happening, by the way. That was a conversation that we had around what we could do that. Is there time for another question?
Just one thing, something I think Peter first told me the story about was people who need the typing to the keyboard. And I just came across a case a couple of weeks ago, a 48-year-old person when they went deaf. So they never learned Auslan. And yet every time they ask for that particular type of equipment, at every hospital appointment they go to, and every time there's an Auslan interpreter there, which is absolutely useless for them because they don't speak that language. And yeah, it's really something to watch out on. The carpet idea though, I don't have a loss of hearing as such, but the top and the bottom of the range of my hearing are a bit out. And I do find that I tend to visit about meal times, which are strange times, and yeah, trolleys going past. I have to ask specialists to repeat over and over again, and they're not happy little chappies, or chapettes, should I say, mostly.
Absolutely. Thanks very much for that question. I agree.
Any quick questions? Wrap up. Yep, we're going to wrap up now. Sorry, we're just waiting to see the other group must be just finishing as well. So
Fantastic. Yeah. I do have one more thing I'd like to finish on if I could.
go for it then.
Thank you. Are you okay? Yes. Would you like to speak?
Okay. Wow. The lady's having a last word. And it's a last word on the importance of consumers. 40 years ago, sociologist Peter Berger, this is 1977, wrote 25 theses pertaining to the consumer of services. These theses were widely circulated during 1981, the International Year of the Disabled. Two of these theses in particular have resonated for us over the years and have been the cornerstone of our advocacy work ever since. To quote, "Thesis 13, each person knows their own world better than any outsider, including the expert who makes policy. Thesis 14, those who are the objects of policy should have the opportunity to participate, not only in specific decisions, but in the definitions of the situations on which those decisions are based." He goes on to add, "What people have to say about their own reality should always be taken with great seriousness, not only because this is morally right, but because failure to do so can lead to great and sometimes catastrophic consequences. These remain just as relevant today." And I'm going to make a consumer statement now that Damon didn't know anything about. I'm going to state that I had such a lot of difficulty hearing and understanding what went on this morning. I've just tuned out this afternoon. The rapid speech is something that my brain cannot follow when the sound is distorted. Thank you.
Thank you, Joe.